to be here with both Preeti and Borna. Excited to learn a little bit more about AgileMD, the use cases and how you're using it at John Muir. But let's start with some introductions first. Preeti, I'll let you introduce yourself first.
Sure. I'm Preeti Patel. I'm a family physician and I serve in the role of Chief Medical Information Officer for John Muir Health. John Muir Health is a community-based health system located in the San Francisco Bay Area.
Wonderful. And Borna?
Hi, my name is Borna Safabash. I am co-founder and CEO of AgileMD. AgileMD is a digital health startup based in San Francisco.
Well, I'm excited to talk to both of you. Borna, we'll start with you first. As a leader of a company, you're always start with trying to solve a clear problem that you saw. So tell us about what are you solving for at AgileMD and particularly with eCART?
Absolutely. So eCART it's an early warning score and a workflow. It's a suite of applications that use machine learning to be able to identify the highest risk patients in a hospital and help get them the right care at the right time in the right place. If you think about whether you're a nurse who's covering 5 patients or you're a hospitalist who's covering a large service, it is really easy to overlook a patient who might be slowly deteriorating or declining, whether it's an abnormal lab value that's concerning. These are things that, as providers, we're all doing the best we can, but machines can do a really good job of being able to identify some of these clues in real time to be able to surveil continuously. And that's a big part of what we do.
So it sounds like this continuous, maybe automated surveillance is part of this. Tell us a little bit more about how the technology works. And Preeti, I'll want to get to hear from you about how this is working in real life with clinicians, with patients. But Borna, tell us a little bit more about the tech. How does that actually work?
Absolutely. So it starts with a score, and so this is an AI predictive model that uses 97 different variables to continuously surveil every patient in the hospital and identify those at highest risk. But that's just the beginning. Paired with that score is a set of workflows, and since the very beginning of this work, what we've learned is that you can have a really good score. In fact, you need a good score, but if nobody responds to it or intervenes at the right time, it won't make any difference. And so we've done a ton of work around workflows that are triggered by this score that allow patients to get assessed and for interventions to take place. So that's one major part of it. And then another is all of the quality improvement and change management that goes around it. So, making sure that Preeti and her team have data around how they are responding to these alerts, whether they're able to get the right interventions in place, and what the compliance and adoption of those are. So, when we talk about eCART, it's really a suite of different solutions. There's the predictive models itself and their accuracy. There's the workflows that go with them, and then there's all the data and reporting and change management that comes with that.
That's amazing. Thank you for going through that in some more detail. Preeti, I want to move to you. What motivated you to start using eCART initially?
So many years ago, in 2016, is when I met Borna and the AgileMD team. We met them because they had a product called AgileMD, which really helped us deliver some of our standardized guidelines into care pathways, which were cleverly embedded into Epic. That's the EHR that we utilize. And so I had learned of eCART through Borna. And so there was a number of different factors that came together. I was the chair of our clinical decision support work group. And one of the items that we've been working on is our sepsis alert. It was overfiring, and our nurses were getting alarm fatigue. And so, no matter what we did to optimize it, it just wasn't precise enough. So when we learned of eCART, we thought, well, this would be a great tool to address sepsis, but then, more than just sepsis, all causes. We hadn't implemented any type of early warning scoring system at that point, but that was in discussion. So the timing worked out, and that's how we ended up moving forward with eCART.
That's very helpful. So it was born out of a actual like nurse fatigue issue while trying to solve the patient's problems as well. You knew you had to do that, but you were also very considerate. Like, we can't have more alarm fatigue. We can't have more false positives. This is not working for us. We need a new and a workable solution. And I like, Borna, what you said too, is like the workflow piece. I do want to come back to that because yes, the tech is very important. And oftentimes people think the tech is the magic bullet, but it's actually the workflow and the adoption. So want to come back to that. But tell us, Preeti, a little bit about why use this all-cause clinical deterioration warning system?
So like all healthcare providers, I think we're all trying to focus on improving patient outcomes. And so the key really is how proactive are you in managing your patients? And so it's always better to be upfront than after the fact. And so this early warning system really gives us time so where we can really improve, we can reduce mortality, reduce the risk of the patient deteriorating on the floor, then ultimately needing the ICU, really reduce the chance that the admission is prolonged. And it gives our physicians and our nurses a tool in their workflow that really can help them identify these patients who are deteriorating. They take care of a lot of patients, so keeping eyes on all patients is not easy. And then all cause, we could focus on just one specific disease or condition, but better is to address all causes.
Can you break that down a little bit more? So you're saying instead of just focusing on sepsis or COPD or one of those conditions, you're looking at multiple potential causes of deterioration?
Exactly. So just looking specifically at the patient, is the patient deteriorating of any cause?
Okay.
So I think the first step is flagging that patient as someone who needs closer attention and an evaluation. And then from there, that's when the clinician would then determine, what is the ultimate cause.
Got it.
And
And go ahead, please.
And for what it's worth, we've studied this extensively. If you look at the cause of the underlying causes of deterioration, sepsis accounts for about 40% of it. But that means that 60% of the time it's something else. And so it is far and away the most, it's the number one. There's no question about that. But in terms of the other top 10 causes, there's a number of different things to consider. And so when you get to workflow and implementation and change management and all of that, it's really challenging if you try to have a sepsis workflow that is separate from a workflow for everything else because it's disjoint. And so really what we want to understand is you may have a patient that's infected, but not necessarily declining or deteriorating. They may be well managed on antibiotics and they're improving. And so the question isn't really whether we're trying to predict infection; it's whether we're predicting someone who's declining and deteriorating. And if they are, they need attention and hands and eyes, sort of regardless of the underlying cause.
That is a very helpful distinction, and it's the full picture, as you said. Otherwise, it could be very disjointed. I'm curious, Preeti, let's talk about workflow and adoption. What was the adoption cycle like for this being part of the nurse's workflow, the clinical team's workflow? And then two, I'm very curious about, there's always a mixed reaction amongst clinicians on like to trust AI or not to trust AI. Can you speak a little bit about how that process unfolded with your teams as well?
Yeah, no, these are great questions. So when we started with the pilot on a unit where I think the nurses were very forward thinking. That's sort of the one unit that we do all our pilots on. So we had a great group of people, giving it a try. At that time, I don't think people were really talking much about AI. So this was 2017 is when we went live with it. And our nurses were performing a very labor-intense screening process for sepsis. And so it took them a few minutes to do that. And then that would, ultimately fire that alert. So it was a tremendous amount of work. At every shift, a nurse would have to do this. So to try to get them to adopt it was actually pretty easy because we were removing that manual workflow and that administrative documentation burden and replacing it with a tool that worked automatically. So that was kind of the initial change management part. It was easier than we thought.
Easy, yeah.
Scaling it became, it was pretty standard change management, really kind of educating people the value of it and how it would help. We had the previous experience of the pilot to share with the other folks, so that made it a little bit easier. our physicians required a little bit more data and information to drive that workflow. So I think from an implementation point of view, it was, it occurred over the course of 6 months, but now we utilize it in both hospitals on all of our medical surgical units.
And I'm sure there's always options to consider whenever you're making a decision on a system. So what did you find that differentiates eCART from other early warning systems on the market?
So I'd say the obvious is that it has FDA clearance. I mean, I think that part is really important to us as a community-based health system. We don't have data scientists that are on staff, and so we need something that's backed by science, something that's tried and true, and has outcomes associated with it. And then the second thing I'd say is just how it is implemented and integrates with our electronic health record. It is not an interruptive alert, so it's the score is seen in the patient chart, and it's even seen in a list. So if I'm a hospitalist and I have a list of my patients, I can see what their eCART score is, and then I can choose at that moment when the moment is right to really look into why that might be elevated. The user interface is really beautiful. So as you go in, you can see how the eCART score has trended over time, and you can really look at the different variables. And as Borna mentioned, there's 97 variables, and so it gives you some insight into, what is it that's driving this
Not a
deterioration.
black box. You can see what is driving it. Yeah.
Exactly. Yeah, no, it's really helpful, to the clinician. And then the second part is you can see how the care team has been managing the patient's instability. So, if the eCART score is high, everyone's documenting in that tool. And so you can see this longitudinally. And then the best part of it is that there's these pathways that were developed for our physicians, nurses, and our rapid response team. So each of them can go in and look at a pathway. So that's the AgileMD part. And then they can look at, what is sort of, they carry out a very standardized thought process, screening process. They place the same orders. And so this is a way that we're standardizing care and really reducing that variation in care.
I love that. Borna, what would you add?
I think the FDA clearance is a big deal as well, but I think it's a big deal because of what it really encouraged and motivated us to double down on. So when we went through FDA clearance, there were a couple of things that the FDA really pushed us on. First was the validation and generalizability of all the data for the performance of the model. So, it went from a data set of today, the data set underneath eCART is 3 million patient encounters from 28 different hospitals across 3 different regions of the United States. Like they really pushed us to try to demonstrate that this model was going to be generalizable across the board. And so that was important for us. It took a fair amount of time.
To one community, not one hospital, one
Right.
demographic. It can actually be used across all types of systems.
And so that was a big deal. What that did is it allowed us to sort of pushed us to get to a level of generalizable performance that when you compare it against other models that are on the market, the positive predictive value and the sensitivity of the tools, they're not comparable. What that means is, when eCART says that this patient has a high score, there was a study done by Yale comparing several different models. And what it showed is that when eCART was elevated, the positive predictive value, so the probability that the patient actually was going to go on to deteriorate, was more than twice as high. And so what that means is that from a trust perspective, if you're a clinician, at John Muir or elsewhere, and you see that a score is elevated, it means a little bit more to you. The other thing that the FDA pushed us on was the usability, the transparency, the understandability, explainability of all of it. And so the user interface that Dr. Patel is talking about is really important, because what happens is when you are, under time pressure and you see this, what the UI does is it shows very clearly, here are the underlying trends that are concerning about this patient. For example, having a high respiratory rate is not a big deal if you're young. It's very concerning if you're old, particularly when combined with certain lab values. And so when you see that all sort of presented, what it means is that when the frontline nurse is messaging the care team and saying, I'm worried about this patient, they don't just say, I'm worried about this patient, say, I'm worried about this patient, and here in 3 quick tidbits are what's concerning. And then a culture develops around it, so that when everybody sees a red score,
Yeah.
they come by and round on the patient again.
Oh, that's really insightful. Thank you for that additional detail. It's helpful to see how rigorous the process is, and also kudos to you on going through that process and really building a product that can be scaled and usable and generalizable, as you said, for different types of systems. Preeti, now several years in, tell us about value. How do you think about value? How does it link to your system level goals? What sort of results have you seen?
Yeah, so we're 8 years in, a little bit more than that. And I would say it is a household term now. I think
Right.
just like a vital sign, people will speak of blood pressure. I mean, the
Mm,
eCART score is a known entity, and it's really how we're risk stratifying patients. We have a rapid response team, and the way they start their day is by looking at those patients that are highest risk. They round on those first, then those who have moderate risk. And I think our hospitalists are doing the same. Is really, if you have 25 patients, who do you go see first? Well, you'd want to address the sickest to the least sick. So I think there's a value in how we approach our patient care at John Muir. And then I think the other value is really reducing some of the manual work. A lot of these risk calculators require time. And so the fact that we have a tool that's working automatically, updating every 5 minutes, reducing our alarm fatigue, those things are really important to us. And then, seeing improvements in mortality and sepsis and other clinical incomes is also really important. One of our goals is really to reduce prolonged hospitalizations. And so
yeah.
this early detection leads to early treatment and, hopefully earlier recovery for our patients. So that's extremely valuable. And then I'll just say two other things. One is communication. I think the team is so important, and this is a team collaboration platform, and that
Mm,
really creates a lot of focus on how we manage the patients together. And then this is a tool that serves all. It's
mm,
monitoring all med-surg units, and so when we think about reducing that variability and detection of deterioration, it really provides equitable care across the board.
I love that you said started off your answer saying it's a household term. I think that just speaks to how useful a product, a tool, a system becomes when everybody just becomes part of the vernacular. So that sounds amazing. Borna, final question to you. Knowing John Muir has been on this journey for a while, but can you talk about how has eCART evolved, as well as what's on the horizon? What should people be looking forward to?
Absolutely. So, again, one of the main evolutions this past year was getting the clearance with the FDA.
Mhm.
I think that was a big step for us, both in terms
Congratulations.
of,
Yeah, yeah.
thank you, both in terms of the sort of the contributions that it made to the solution itself, but I think also as for a company like us, a better understanding of sort of how the FDA thinks about this space and what it means for the roadmap of what we are working on. I think, what's been really exciting to see is that if you look sort of, including John Muir, but it's sort of across the board, all of the health systems that we work with that utilize eCART, we've been able to show a 40% reduction in adjusted odds of mortality. So
Mm.
mortality impact has been dramatic. I think
Wow.
part of what we are understanding now is that the population of high risk patients accounts also for a really significant proportion, almost 60% we saw, of the patients that stay additional days in the hospital, sort of beyond where their hospitalizations are extending beyond what would have been expected. And I think in those situations, again, it just highlights the importance of being able to identify these patients early, be able to get hands and eyes on them, understand how they're contributing to all the quality measures for that hospital. And so that's a big area that we're looking at today too.
That's amazing. Well, as we conclude this, firstly, thank you both for this discussion. And I'm just reflecting on this conversation. We have a lot of discussions with health system leaders. When you think about the macro trends of the supply demand problem, a lot of people refer to it as the 2030 problem, when we'll just have a big shortage in physicians and clinicians, as well as an older, sicker population. I think these are the types of solutions that actually work. like you can do more with less, and they solve real problems, and they solve it well. So kudos to you, Borna, on building this and scaling this with so many health systems. And I can see this is going to be a real tangible solution for so many more. And Preeti, your great work in making this real and leading your teams through this as well. So thank you both. I'm excited to share more about AgileMD and your work with others as well.
Thank you, Sonia.
Thank you.